Hello, I am Althea Maria Papulias, president of the Daughters of Penelope Vienna. We have organized this women's cancer panel discussion because we believe in civic responsibility. You will hear an empowering and exciting panel of some of the greatest experts in the world, including a young fourth stage breast cancer survivor who is helping to change women's lives in Austria and Europe. If you like our videos, you will have the opportunity to help the Daughters of Penelope raise funds for psycho-oncological treatment at the Cancer Center of Vienna. So please donate. Thank you for joining us and enjoy our wonderful panel.
A very special person who's also been instrumental in supporting us here at the Daughters of Penelope, a specialized radiologist who's also specialized on the breast, and radiation oncologist with a strong focus on breast cancer. She's been 29 years at the AKH. She's also been, this is what I thought quite interesting, was in 2014 you became head of screening of approximately this National Breast Cancer Early Detection Program. So that's the exciting part of the introduction. Now we're going to start with our questions. The vaccines and the chemo, over to radiology. So with Alexandra, the screening program in Austria, the free screening program, has been existing for 10 years. What has happened during this time, and can you tell us what misconceptions we have?
First, just I have to mention that in Austria we had free screening before, but it was a grey screening. About 20 years before, we had a free possibility for all women to have a free mammogram, ultrasound, and examination, clinical examination. Then we did not have a population-based screening with invitation system. That's what we implemented in 2014. But this was also the problem, because the women, they were used to have a clinical examination, they were used to have ultrasound, and now they are just getting a mammogram. I think we are the only country, after implementing a screening program, the rate of mammographies dropped about 25%. It's really very, very unusual. And so we had to do a lot of convincing people that's the same, or that's even better, because it's more standardized, it's more quality standard, and so on. This was in the beginning, the first 2-3 years, it was really a problem. For screening, it's the same problem as Dr. mentioned with the cervical cancer screening. There is a big part of the population who does not want to attend. In cervical cancer, it's about 40%, and I'm a radiation oncologist as well, and we see that about 85% of all cervical cancers we see are coming from this part of the women who do not want to attend. And maybe that's the possibility to get them if they have the self-testing. Mm-hmm. And I think we are not in Sweden, or we're not in the Netherlands, where all screening programs, they work very, very well. We have the same in the mammography screening. We have about 40% who do not want to attend. Then mm-hmm. The rate now is about 58%, and it's very similar to the German one. In Scandinavian countries, about 70 to 80% attend, and in UK that's the same, over 80%, and we cannot move forward. We don't reach the people. If you have more PR or whatever, then the same women come every half year or whatever, and we can't reach these women where the disease hides.
Yeah,
that's the problem.
So, but there's a misunderstanding. I think. Remember, we talked about how people have this false impression, yes. And that's probably why they don't go to the screening.
Yes, there's a big misunderstanding. We have a lot of journals who describe the disease and they are warning about it. But I asked some patients today, what would you think is the average age of a woman in Austria developing breast cancer? And because of all these articles you can read, these are mostly younger women, because that's more tragic. There's a woman age 35, age 40 with small children, then you're really touched by this fate.
Sorry.
But actually, the average rate in Austria for getting breast cancer is 62. The most will think below 50. This age, around menopause, women are feeling a lot of stress. the hormonal situation differs from before, and they can feel some pain in the breast and even some lumps sometimes, and these are mostly cysts. That motivates them to go to the screening. And usually this stops after the menopause, and then that's also exactly the age when they stop to go to the gynecologist. And then not one patient of mine, a lot of them, they told me, oh, now it's over. And then I always said, it's not over, it just started.
Right. Yes.
And it's not stopping even at 60, at 70. And so the Austrian program is, I think it's a very good program. It's from 45 till 75, and you can opt in to have it from the age of 40. And if you would like to stay in the program, you can do this after the age of 55 as well, 75 as well. So it's open end. I like this because the participation rate is dropping, but these women who want to participate should be able to do so.
Because they have the interest in it. What effect does screening have on the mortality, and what's the future of screening?
We know there's quite good evidence that screening can drop the mortality rate about 30%. That's quite interesting because only a diagnostic method is able to lower the mortality rate. That's just because we are finding more early breast cancer with a quite better prognosis, and then we can avoid the later stages when the prognosis is much worse.
Yeah, and so, and one of the things we talked about a little bit was how some of the challenges that you have in being to diagnose with the mammogram, that there are some other alternatives that are also available to our public that they should be aware of.
Yes. Now, the only method which has been proven to lower the mortality rate is mammography up to now. But we know from other studies that perhaps for women with a very high risk, then mammography alone is not enough. So now we can use mammography, sonography, ultrasound, and as well MRI mammography, which is the most sensitive method, and we can find a lot more cancers if we will use the MRI. But if we will use it for the average population, then we will find a lot of changes which are not cancers. So now this is restricted for patients with a higher risk. In the US, we are recommending MRI screening for patients with a risk more than average, about 20%. Lifetime risk, and normal person has a risk of 1 to 8, which means about 12%. And of course, the high-risk screening for patients like Angelina Jolie with a BRCA mutation, she has a risk of about 80% up to the 50 years of age. And those, then of course, you will find many more cancers, and then and you can discuss it. And of course, you will have some unnecessary biopsies as well. But for this special population, they will accept it, of course.
Yeah, and you mentioned that because of this, if you have dense breasts, you're entitled to different types of screening in Austria as well.
Yes, I think we should move on from this concept of mammography screening is from the 70s. It works very well, yes, but I think we could do better. I think we should move on to a more personalized screening. We should define risk populations, and then now we do that for high risk, we do that for more than average people, and we could, based on the breast density, and because in breast density we have less contrast, and therefore the mammography is not so accurate like it is in a patient with less dense breast. So we should base on density, family history, and some other risk factors, which we know already. Then we can maybe switch to a more personalized screening, having MRI for patients with higher risks, and mammography or beta tomosynthesis for those with lower risk. And I think we are moving on to this.
So personalized screening,
yes,
with all multi-factors.
The Austrian screening program is unique because we are the only one we have a mandatory ultrasound for breast density C and D for the more dense breasts. So that's better than nothing. But of course, I think we should get out some women with a higher risk and put them into MRI screening.
And you mentioned that, there are also sorts of things to increase the sensitivity of your diagnosis as well.
Yes, but that's always the same. If you increase the sensitivity, you might lower the specificity, and then you will have more unnecessary biopsies. Therefore, you should restrict these methods for groups of patients where you will find more cancers.
Right, because the whole issue, you had a very interesting point about should I go to a screening or not, where you said there's the individual view and then there's the public health service view.
Yes, that's a question I'm asked daily. So should I go to screening? And it's not so easy because we have two different views. We have the personal health, the public health issue. Then if we do screening, we can avoid 30% of breast cancer deaths. That's absolutely true. But on the other hand, that's not the same like a personal decision. My personal risk, we can avoid. We have not so many cancer deaths, but if you take it from the whole population, then that means we will have about 1,000 breast cancer deaths less. So what we are doing for 1,000 less deaths in traffic, we're doing a lot, and that's the same. We will for the population-based thinking, we will have many saved lives. But on the other hand, if you go to mammography, you have to be aware that we can save 1 or 2 women out of 1,000, which is not too high. So if you're just thinking from your personal point, then probably you won't need it. But from the point of the...
you are. You might be the
you
one or
don't
two.
know. You might be the one or two or not. So if you're calculating your own risk, that maybe your own risk of getting cancer. But this is also true. If you are participating in a breast cancer program, you will lower your personal risk of dying of breast cancer about 50%. And that's not so bad.
That's right. And we've already heard that Dr. Aptis had talked about how catching it early gives you a lot of options. Now let's talk about the radiotherapy, the treatment of breast cancer, because you also work, and you're one of the top specialists for this. And you talked about how that has changed from the aggressive, massive mastectomy, and how also it's become much more targeted so that the survival rate is higher because they found out several things.
For radiotherapy, I think it was very, very important for the development of breast-conserving therapy, because in the 80s, mastectomy was the treatment of choice. And of course, this was not necessary, and there were a lot of studies beginning in the late 80s and early 90s where we could show that breast-conserving therapy, which includes radiotherapy, is just the same outcome like mastectomy. And in 1991, I think it was recommended as the treatment of choice for early breast cancer. And I think this was quite important because in former times, women do not like to go to a mammography and do not like to have any examination of the breast, because they know if we will find breast cancer, then it would end up in mastectomy, even if it's a small one. And in Austria, we had a very promising idea there was the first publication in 1927 of breast-preserving therapy with radiotherapy in the Vienna Clinical Wochenschrift. But unfortunately, this was from the Wiener Jüdischen Krankenhaus, and in 1938 this was stopped, of course. But then we could have this idea much earlier. Yes, and from that on, when women know that getting it earlier, then that means you can keep your breast, and that's no mutilation and no mastectomy. Then from then on, I think it was also more popular to go to a screening examination.
But then you changed your radiotherapy. How you execute your radiotherapy is now totally different.
Yes, of course, we have some technical development. When I was in my education, I always learned radiotherapy had a big impact on local therapy, but it has no impact on survival. And I always asked, why? when you have such a high impact on local recurrence, why could we have no impact on survival? It's impossible, because even some recurrences may end up in a metastasis, and so we should have an impact on. And this was proven only in the, I think, around 2000 we saw the first time. And the reason was we always had a better, we had an impact on the cancer-specific survival, but we had no impact on the overall survival, which means that these women we had treated, they are not dying of cancer, but on something else. And something else was some diseases of the heart. And then now we are able to have an image-based, three-dimensional treatment planning, and now we can avoid organs of risk, like the heart, like the vessels, and therefore we have not so many heart diseases in the follow-up. And now, with modern techniques, this effect of having heart problems could be shown that these are not existed any longer, and we have now the impact of overall survival as well. And we know that about for 2 or 3 recurrences, we can avoid 1 breast cancer death.
And so really the world has changed quite a bit, and with the use of radiotherapy. Now, you mentioned that AI could also have a role in the future treatment of for radiotherapy.
For radiotherapy and even more
for screening.
For screening. We use it in radiotherapy because for delineating, for drawing the target volume, and so we can irradiate less volume, and so we have less side effects, and we can increase the dose and decrease the side effects, which is always the main question in radiotherapy. Also the same in cervical cancer. Radiotherapy is very, very effective in cervical cancer as well, but we could not deliver in former times the accurate dose just to the tumor without destroying other organs of risk. And now we can, because we have a more sophisticated schedule to plan it.
And you mentioned also in the screening because of the pattern recognition.
Yes,
yeah.
AI is somewhat, so we can use AI also for having a better images. They are implemented in a lot of machines as well, but we can use it also as pattern recognition. And so, because there are some features that can be extracted by AI, which can't be seen by the human eye.
And so it's great that we've seen so much progress, in a sense, for the treatment.